I'm Levi, one of the R2s, and I'll be talking about pelvic floor physiotherapy. I selfishly chose this topic because I hear it mentioned all the time and I didn't really know what it was. So I will tell you all about it this morning. But before I start, I'd like to thank Dr. Kavanaugh for helping me put together this presentation and kind of going through it with me. So today I'll start off with a brief review of anatomy of the pelvic floor before getting into what pelvic floor physio actually is. Then we'll go through what it can be helpful in treating and which patients could possibly be referred. Then I'll talk specifically about pre- and post-op evidence for pelvic floor physio. So we can get started with some anatomy. Before I go through, I want to credit the UBC anatomy resources for the images. I use them a lot throughout medical school, and they came in pretty handy when I put together this presentation. So this is an outside looking in view of the pelvis and the pelvic floor. We commonly refer to the levator ani as a single entity, but it's actually made up of three muscles. So most anteriorly, we have the puborectalis, then the pubococcygeus, and the largest of the three, the iliococcygeus. They're pretty important muscles for defecation and urination. When they relax, they increase the angle between the anus and the rectum to help things move through and out. And when these muscles are tight or spasm, they can kind of cause some chronic pelvic pain that's associated with that tonicity. So physical exam for these muscles might involve palpation through the rectum or the vagina, depending on the parts your patient has. And then also included in the pelvic floor is the coccygeus muscle, most posteriorly. So although anatomy is pretty similar in males and females, I'll go through the females first. So here we have in blue the perineal membrane. It's a fibrous fascia that connects to the pubic arch and perineal body, and it separates the deep and superficial perineal pouches. In females, the deep perineal pouch in the red orangey color in this picture is a potential space that contains parts of the urethra, the vagina, the external urethral sphincter, and the pudendal nerve. So these structures in the deep pouch are quite important for continence. And then we have the superficial perineal pouch that's in pink, and this contains the erectile tissue, some branches of the pudendal nerve, and the superficial transverse perineal muscle. These are the remaining perineal muscles in a female. They include the ischiocavernosus, bulbospongiosus, superficial transverse perineal muscle, the external anal sphincter, and the perineal body. The bulbospongiosus muscle is important for things like clitoral erection and secretion expression in female people. The perineal body is a point of stability in both the male and female perineum, and it's where kind of all these muscles come together and join in the middle. So now we'll look at some males. So they have the same structures, but they look a little bit different. And again, perineal membrane here is in the blue. And males have the deep and superficial pouches as well. And they have all the same structures as in the female, just without the vagina, obviously. And the deep pouch here in orangey red color, the superficial again in pink, and encompasses most of the penis, the erectile tissue. And the muscles of the perineum in the male are essentially the same as those in the female. They include the ischiocavernosus, bulbocavernosus, superficial transverse perineal muscle, the external anal sphincter, and the perineal body. In males, the bulbospongiosus muscle is important for ejaculation and maintenance of erection because it increases the pressure within the corpus spongiosum of the penis. And then this slide here is to illustrate that there's also pretty significant innervation going on down here. One nerve that we tend to block or mention frequently is the pudendal nerve. So it's a mixed motor and sensory nerve and functions to carry sensation from around the anus and perineum and control the muscles of the pelvic floor, including the bulbospongiosus, ischiocavernosus, the levator ani muscle group, the external anal sphincter, and the male urethral or female external urethral sphincter. So if this nerve gets damaged or stressed or purposefully blocked, like we do sometimes, it can cause some saddle anesthesia. It can be stressed commonly by things like childbirth or chronic constipation, but it can also rarely be stressed by things like avid cycling, which can lead to something called Alcock Canal syndrome. So this can present as chronic pain of the perineum that gets worse with sitting. It can cause fecal or urinary incontinence, or it can even contribute to things like erectile dysfunction, premature ejaculation, or vestibulodynia. Then we have the fourth sacral nerve, which also provides important innervation to the levator ani muscles, which are important for pelvic floor health, like we mentioned, and urination and defecation. Okay, so we've reviewed the anatomy. So now we can talk about what pelvic floor physiotherapy actually is. So just to start off, I have some definitions that I Googled. It's a specialized form of physiotherapy focusing on the rehabilitation of the pelvic floor muscles. It's a specialized form of therapy designed to treat the tissues, nerves, and muscles in the pelvic region. It's a specialized branch of physiotherapy involving internal and external assessment and treatment of the pelvic floor muscles. And it's done by physiotherapists with special training in the area. Now to get a bit more detailed. So according to the International Continence Society, there's 3 different levels of pelvic floor physiotherapy training. So the first level includes evaluation and treatment of simple underactive pelvic floor muscles and all pelvic biomechanical dysfunction, as well as vaginal examination. Level 2 includes all those same level 1 skills, plus the evaluation and treatment of hypertonic pelvic floor muscles, pelvic pain. It includes the use of electrical stimulation, manometry, and biofeedback in the treatment of the pelvic floor muscle dysfunction. And it also includes rectal examination of the pelvic floor muscles. And then the third most advanced level includes evaluation and treatment of all pelvic floor muscle dysfunction in all populations, and this includes sexual dysfunction and treatment of children, elderly, and people with neurological pathologies as well. So depending on the level of training the practitioner you're referring to, your patients may be receiving actually quite different levels of care. Typically, though, all patients are assessed with history and some sort of physical exam to allow the physiotherapist to come up with a care plan based on the patient's specific needs. So this can include strengthening with things like Kegels or quick flicks, or it can focus on relaxing the muscles if increased tone is a problem, and that can include things like trigger point release. Breath work and learning how to flex and relax specific muscle groups in the pelvic floor and the abdominal wall are usually important aspects of their treatment. Sessions are typically 30 to 60 minutes each, and people will commonly see a physiotherapist once a week for about 4 to 6 weeks. And like any physiotherapy, you don't actually need a referral from a doctor, so anyone can go. If you feel like you want to try it, you can just sign up. And if you have health benefits, it might be covered as well. Otherwise, it is private pay in Canada. So these are some exercise regimen examples from Urology San Antonio. They had an article on their website for specifically post-prostatectomy exercises. The point of the slide wasn't to go through each of these exercises, but just kind of to illustrate that it's more complex than just instructing patients to do a bunch of Kegels and send them on their way. So for fun this morning, I thought to see what our patients are doing. We can try number 4 here. So while you're sitting in your chair, sit up straight. Squeeze your pelvic floor while you also squeeze your knees together. And then you hold it for 3, 2, 1, and then release. So that is supposed to be repeated 15 times a day. So feel free to keep practicing that or any of these other moves for the rest of the presentation to see how hard that is to do, see how hard or easy that is to do the recommended 15 times a day that some of our patients are being told to do. Okay, so while you're practicing, I'll tell you about the different types of pelvic floor physiotherapy. The most simple, but also probably the most accessible, is just at-home exercises. So this is something like I've shown on the previous slide where the patient is given instructions on how to do exercises and then encouraged to do them at home. The other two listed here actually require physically going to see a physiotherapist. So biofeedback is done with a physiotherapist, and it's done either with a machine that monitors contractions and shows the patient when they're contracting, or the physiotherapist is physically putting their hands on the patient and then giving verbal feedback about their contractions. So if they're contracting the correct muscles for the correct amount of time, etc., the patient actually gets feedback on that. Then there's electrostimulation. So this involves artificially contracting muscles with external energy, and it's usually used to train very weak muscles into working again. And sometimes in these cases, the patient is encouraged to try to also manually contract those same muscles right after the electrically stimulated contraction. And then kind of on the opposite end, when things are too tight, there's also manual trigger point release. So this is essentially a massage like you would get on your back when you have trigger points, how they hold pressure to help release that. This is that same thing, only for the pelvic floor. So it's accessed via the perineum, the vagina, or through the rectum. And it can help relax very tense muscles to help relieve pain or help with issues like constipation, where the relaxation of those levator ani muscles is pretty critical for release of the feces. Okay, so which patients should maybe be referred to a pelvic floor physiotherapist, and which conditions should we consider it for? There's many, but I'll start with females with urinary incontinence. So they're one group that can possibly benefit. As you know, pretty common problem, and I found one article that reported that in women over 65, up to 10 to 20% reported incontinence, but this was likely underreported, they felt, because it's a pretty embarrassing issue sometimes. So there are different types of incontinence, as I'm sure you're all aware. It includes stress, overflow, urge, fistula, incontinence, congenital malformations, and functional differences. So the main risk factor for urinary incontinence in women is thought to be childbirth and pregnancy, although things that increase abdominal pressure like obesity or heavy weightlifting can also be risk factors. Specifically, though, vaginal deliveries have been shown to disrupt the nerves and levator ani muscles and also cause increased urethral mobility. So all of these things can contribute to incontinence. So the role of the pelvic floor physiotherapist for incontinence is first aimed at locating the appropriate muscles and then teaching the patient how to contract them. This is then tailored to each patient in terms of which specific exercises they do, how many reps, and the duration of the exercise to strengthen those specific muscles that they found were weak. So the strengthening technique for this type of incontinence is because the bladder neck is supported by the pelvic floor, and if it's stronger, it can limit the downward motion of the urethra to help prevent incontinence if it's adequately strong. So a systematic review here included 107 articles that looked at effects of non-surgical interventions on female urinary incontinence. It was a pretty vague article that didn't include much specific data, but it was more of a summary article. They reported that typical regimens focused around Kegel exercises with 8 to 12 contractions 3 times per day. The duration of this in the studies varied, but it was concluded by the authors that if the physio was working, it was generally recommended to just keep practicing the exercises indefinitely to help keep up that muscle tone, especially since this is occurring in a lot of older, more frail women. So the regimen was found to be most effective for stress incontinence specifically, but there was one method that they found to be effective for urge incontinence. So it was called the quick flick. And that's where you contract your muscles 3 to 5 times quickly when you feel the urge to void. And they found it helped relieve the urge and prevent incontinence that way. Something else that was found to be effective for urge incontinence and overactive bladder that I won't really get into in this talk is nerve stimulation. Overall, this article concluded that pelvic floor exercises were effective at improving symptoms for 70% of women and 66% were found to still be continent at 10 years follow-up. It was safe. There was little to no adverse events documented in any of the articles they looked at. But again, this specific review was pretty vague, and they didn't get into how they decided to report those particular percentages that they found. So results from the vague article were, however, echoed in this Cochrane review that I found that looked at 31 trials that included 1,817 women with any type of incontinence. Their aim here was to assess the effects of pelvic floor physio specifically on women with incontinence as compared to a control group. They showed that pelvic floor physio was more effective in curing or improving stress incontinence than having no treatment, or the controls in all of the studies they looked at. And you can see in the figure here, there were little conclusions made in this article about urge incontinence, because the articles they included didn't end up looking at urge incontinence alone, but it was included in the studies where they looked at all types of incontinence, which is the bottom section of that figure. They also included that pelvic floor muscle therapy was effective at treating all types of continence. So the type of physio studied in most of the articles that were included in this review was done by a physiotherapist with the women attending sessions regularly. Again, there were little to no adverse events noted. However, they did acknowledge that the expense of the sessions was not specifically studied, and so cost effectiveness wasn't fully reviewed in this article. But going forward, cost is something I won't really get into, but it is not covered here, and so finances could be a barrier to accessing physio for our patients that don't have extended health benefits. So it's just something to keep in mind kind of while we go forward.
Levi, before you leave this slide, how many of these in a Cochrane review, they usually only look at randomized control trials?
Mm-hmm.
Were these actually prospective, protocol-directed, endpoint-defined, inclusion criteria-defined RCTs? So in other words, how robust is the level of evidence?
I believe most of them were RCTs. I can't remember the specific number off the top of my head, though, for this article. But I believe most of them were RCTs.
Okay. It'd be interesting just to know a little bit more about the control group and how they were managed. That's all. Because that's
the controls for most of these physiotherapy articles, kind of throughout my talk, the controls were either called same as usual care. So that included either like handing out a pamphlet or literally doing nothing. And then some of the other controls were specifically doing nothing. So that was kind of mostly true throughout all of the reviews I'll talk about. Okay, so this was another Cochrane review that was published 4 years prior to the one I just talked about. And it included 21 articles and had the exact same conclusions, unsurprisingly. And it showed that with the inclusion of an additional 10 articles from the previous review, the pelvic floor muscle training was still found to be effective at improving the stress urinary incontinence. And it was also found effective at improving the urge incontinence when you included those all types of incontinence studies. But I think these two reviews kind of also show that studying effects of pelvic floor physio on urge incontinence specifically might possibly be an area that hasn't been studied as much, which could be interesting. So talking about females, now we'll talk about males with incontinence. So like in women, it's common, maybe not as common, but still around 32% for men of all ages. And this was increased to 69% if post-prostate cancer or BPH treatment was included in the survey. So one systematic review looked at 39 randomized control trials that studied pelvic floor physio as treatment for incontinence. So this included post-prostatectomy or just generally for incontinence patients. So I'll talk more about pre and post prostatectomy specific data later, But generally, this group found that all forms of physio that were studied, including pelvic floor exercises with or without biofeedback and electrical stimulation, were overall helpful in improving incontinence symptoms in men with all causes of incontinence. They did note that better results were achieved when the men were actually seeing a physiotherapist or when the biofeedback was used. Most exercises focused on contracting the anal sphincter or urethral sphincter area. So changing gears a little bit away from incontinence, this Cochrane review looked at men with chronic prostatitis or chronic pelvic pain, which they defined as pelvic pain that is present for at least 3 of the last 6 months with no other identifiable causes that have been detected. So this was reportedly responsible for 8% of clinic visits in the US, so clearly a common issue that can decrease quality of life. So this was a somewhat small study that looked at pelvic floor physio as a treatment for chronic pelvic pain. They included 14 men over the age of 18 with idiopathic chronic pelvic pain who did not have incontinence or prior prostatectomy. They were treated with physio, including palpation of the pelvic muscles, therapeutic exercises to help with range of motion, specifically mobility and strength, biofeedback, and neuromodulation for muscle relaxation. And they were evaluated using the GUPI and NIH CPSI scores. So in this study, 50% of participants had a GUPI score that decreased by over 7 points, which was classified here as a robust response to treatment. 20% had a moderate response and 30% had no change, but they did note that not a single participant got worse by doing the physiotherapy. So this study was obviously limited by having only 14 participants, with only 10 ended up actually completing the 10 sessions, and there was also no control group in this study. But since there's no real downside out of time and cost, it shows that it might still be worth a try for these patients that have pelvic pain with no identifiable cause. And kind of like it's mentioned in several of these articles that a lot of the patients noted that it helped give them a sense of control over their condition as well. So it helped them feel like at least they were trying to do something to help improve their conditions that are often otherwise kind of hard to treat. Okay, so chronic pelvic pain, often included in the definition of sexual dysfunction, especially for females. So in this review here, they included 32 studies, including 27 systematic reviews and 5 RCTs looking at female sexual dysfunction, including things like vaginism, dyspareunia, and chronic pelvic pain. Treatment included physio, where physicians or physiotherapists performed myofascial release of trigger points along the pelvic floor. They did this by inserting fingers into the vagina and essentially massaging the pelvic floor. They also provided relaxation techniques and stretching and strengthening techniques of both the abdominal wall and the pelvic floor muscles. Outcomes reported among the various studies, again, were vague without much actual numerical data, but they did report that it improved female sexual function index scores and increased their empowerment. Of course, females aren't the only ones who experience sexual dysfunction. So one component of sexual dysfunction for men is premature ejaculation, which is defined as persistent or recurrent pattern of ejaculation during partnered sexual activity with 1 minute of vaginal penetration or before desired ejaculation, and is estimated to have a prevalence of 30 to 40% worldwide. Again, these people often feel embarrassed or ashamed, so this number might actually be higher. And according to one review that looked at 37 articles studying pelvic floor physio as treatment for premature ejaculation and erectile dysfunction, they found that there was a reported success in 54 and 61% of participants with premature ejaculation. A couple of the studies that were included specifically looked at pelvic floor physio as treatment. They both centered around training the muscles related to the ejaculatory reflex, and specifically looked at timing contractions of the pelvic floor. The physiotherapist helped these men locate their muscles and strengthen their contractions. And these authors noted that those that were not cured failed to recognize when to contract their muscles. But this was another review that didn't specify much data. It was very vague. So it made me dig a little deeper, and I found a systematic review from last year that included 13 studies looking at non-pharmacologic treatment for male sexual dysfunction, including premature ejaculation. So this review included more than just pelvic floor physio. It also included things like exercise, or just electrical stimulation alone, or different combinations of these three. So the table here shows that 2 studies specifically looked at premature ejaculation. Both of these studies used intravaginal ejaculatory latency time as their outcome, and they compared this to duloxetine use. So one study had running and walking for 30 minutes daily for 30 days as their intervention. They included 35 men in their intervention group and 70 in their control. Then the other study had physio with biofeedback and electrical stimulation for 60 minutes every week for 12 weeks as their intervention. They included 19 men in their intervention group and 21 in their control. So the exercise group found that their participants had similar improvement in intravaginal ejaculatory latency time as the duloxetine group, but were taking no medication. And the pelvic floor muscle training group found that there was a 51% improvement in intravaginal ejaculatory latency time, and they concluded that it was actually beneficial in treating premature ejaculation. But I think what this review mainly pointed out, especially that it's from this year, is that there's a lack of literature in this particular area. But pelvic floor physio might be a pretty low risk option for those with premature ejaculation. Again, just something that they could try. So that review I just talked about.
Can I ask a quick question? I don't know if you're going to touch on this later. Did you look into at all climacturia, which is fairly rare, but we see it occasionally post BPH?
It is mentioned a little bit in a few slides. Yeah.
Okay, I'll wait for that then.
Okay. So the review I just talked about for premature ejaculation actually included mostly articles looking at erectile dysfunction. So I'll talk about that now. So it's usually defined as consistent or recurrent inability to attain and or maintain penile erection sufficient for sexual satisfaction, often treated with medication, but pelvic floor physio might play a role. So this is based on the function of the bulbocavernosus muscle. It functions to apply pressure to the deep dorsal vein of the penis when it's contracted, so this helps prevent blood from leaving the penis during erection. So this is from that same systematic review I just talked about with the premature ejaculation. So 11 of the studies specifically looked at erectile dysfunction. It included all causes of ED and severity from mild to severe. All the studies used the International Index of Erectile Function as their primary outcome, and they assessed erectile function at baseline. Follow-up ranged from 5 weeks to 6 months. And 9 of the 11 studies compared the intervention to typical care. 5 of the studies included pelvic floor muscle exercises as their specific intervention, again, because this review looked at just generally non-pharmacologic interventions. So the table here summarizes the findings, and I've put the boxes around the studies that looked at ED with pelvic floor muscle exercise as their specific intervention. And as you can see from the table, all reported some level of benefit from pelvic floor muscle exercise on erectile dysfunction. Something might be of interest is that the Lin et al. Group looked at specifically post-prostatectomy patients. And like the others, they also reported that it was successful. They reported 3 10-second contractions twice daily in 3 different positions was found to be effective at improving erectile function for their post-prostatectomy patients. Okay. So this next study is a bit older, kind of older than me, from 1993. It included 150 impotent men aged 23 to 64 and studied the effects of a pelvic floor training program compared to surgery on their erectile dysfunction. So cavernosography was done on all the patients to confirm that they had venous leakage as the cause of their ED. So the physio arm received a minimum of 5 lessons on an outpatient basis by a physiotherapist. And in these sessions, they were taught anatomy, how to palpate and contract their ischiocavernosus muscles. So they were taught to do home exercises, prone, sitting, and standing. The surgery group had a procedure where they dissected out and ligated the circumflex veins, branches of the dorsal vein, and the deep dorsal vein. They then resected out the deep dorsal vein. So that was the surgical option. All patients, 6 out of those 53 physio patients had a complete response without surgery. So it is a low risk way to possibly maybe avoid surgery, according to these authors. And as you can see on the graph on the right, over time, the group that was treated with physiotherapy actually appeared to have more durable results 12 months post-treatment, but this was not statistically significant. So this may not be as high quality evidence as the systematic review, but it was unique in that it compared to surgery rather than a medication or some other form of therapy. Okay, so pelvic floor physio, helpful in treating, or possibly helpful in treating most of those presentations we just talked about. So now I'll go specifically into pre-operative evidence for published in 2005 and look at perioperative pelvic floor physio for women undergoing incontinence and or prolapse surgery. There are 30 women in each group. Inclusion criteria included needing incontinence or prolapse surgery, and they were able to speak or read English. Women were excluded if they had any concurrent neuromuscular condition. So in their control group, didn't have entrance, as shown in that chart there. Also didn't contain any prolapse-only options, unless Xanthine and spoken patients are programs that where you learn to rapidly flex and unflex your muscles. They were also given written instructions and reviewed by physiotherapists on post-op day 2 and seen again at 6 weeks. The control group received standard perioperative care with no pelvic floor physio instructions or physiotherapist visits. Prior to any treatment, they were evaluated based on a 48-hour voiding diary, urinary symptom-specific health and quality of life questionnaire, and a paper towel test where they drank a set volume of water or waited a specific coughs with a full paper towel in their knees. All the women had their pelvic floor assessed preoperatively as well. Then 3 months post-op, these were all measured again. The physiotherapist, so pull up here. So this was, and my camera is off just to see if that might help me be able to stay in the Zoom. So this group out of Japan did a randomized prospective study looking at pre-op pelvic floor muscle exercise and continence recovery following HOLEP. They included males aged 50 to 90 with dysuria symptoms for over 3 months and prostates larger than 30 cc's. Those that would be unable to do exercises on their own, had severe cerebrovascular disorders or spinal cord injuries were excluded. The primary outcome was self-reported continence post-op with no pads used, deemed as having complete urinary control. Secondary outcomes included quality of life, detrusor overactivity, volume at first desire to void, maximum capacity, and residual volume. The pre-op group started pelvic floor exercises 28 days before their HOLEP, and they continued post-operatively. The post-op group only started post-operatively. They had 35 men in each group after 1 in each dropped out. They measured various factors at 3 days, 1, 3, and 6 months post-operatively, and these included IPSS, OABSS, ICIQSF score, G8 score, and urodynamics, which were all done pre- and post-operatively. Prostate volume, operative time, enucleate prostate weight, and presence or absence of diabetes were also taken into consideration. This paper didn't go into details of what the exercises were, if a physiotherapist was involved, or what their regimen was like at all. But overall, they showed that the preoperative group had significantly lower incontinence rates at 3 months post-operatively, but this equalized again at the 6-month mark. The pre-op group was noted to have a 0.56 times and a 0.08 times lower risk of being incontinent at 1 and 3 months post-HOLEP. Urodynamics was not significantly different between the groups. So ultimately, they showed that the pre-op pelvic floor physio might help early recovery of continence following HOLEP, but it generally equalized out. And this was the only study on HOLEP that I could find. So unlike HOLEP, prostatectomy was quite well studied. So we can look at this retrospective study. I might skip just to the meta-analysis on these just because we're running out of time. Okay, so this one is a meta-analysis from 2016 that looked at effect of preoperative pelvic floor physio on incontinence following radical prostatectomy. They included 11 studies, some of which were the ones that I would have talked about if my Wi-Fi didn't quit. So there were 7 studies that had enough data for overall analysis at 1, 3, and 6 months post-op. They showed that overall, there was only a significant difference in continence outcomes between groups at the 3-month mark. And when looking at quality of life, there was an improvement at 3 months in over half the studies and continued improvement at 6 months for 2 of the studies in the treatment group. So the authors of this meta-analysis concluded that preoperative pelvic floor physio helped to achieve earlier continence following prostatectomy, but did not affect overall incontinence rates. So this is another meta-analysis that was done on the same topic a few years later in 2021. It included 12 studies and found sufficient data in 11 for analysis at 1, 3, 6, and 12 months postoperatively. So this is slightly more than the 7 included in the one I just talked about. So when we're looking at the specific studies, though, they were pretty much identical, and they had the same conclusions, and surprisingly, that 1, 3, and 6 months post-op, there was a lower incidence of incontinence in those that received the pre-op pelvic floor training. And then similarly, there was no significant difference at 12 months, suggesting again that pre-op muscle training might improve time to continence, but not overall achievement of continence post-prostatectomy. So similar to preoperatively, there was quite a lot of literature about post-prostatectomy pelvic floor physio. So here we can look at a few articles that looked at incontinence post-prostatectomy. So this one is an RCT from 2008 that looked at physiotherapist-led physio versus written or verbal feedback, our instructions from a nurse or urotherapist. So the physiotherapist-led group received physiotherapist-guided pelvic floor muscle training once a week for 45 minutes each, and it was started after their catheter was removed. They were also given oral and written instructions for them to do 3 sets of 10 contractions daily at home. Each contraction was to be held for 6 to 8 seconds and then followed by 3 to 4 fast contractions. The primary outcome was self-reported continence at 3 months. This was defined as not needing any pads. Secondary outcomes were continence status using 24-hour pad test, perceived problems with urinary function, and pelvic floor muscle strength at 6 weeks, 3, 6, and 12 months post-op. So this group found that at 3 months there was no difference in continence between the groups according to pad usage, but they did have significant differences in perceived problems with urinary function. In the intervention group, nearly everyone at 97% reported that they had no or mild problems, compared to only 78% in the control group that felt that way. So at the 6 and 12-month mark, the intervention group was significantly more continent. So this was a bit interesting given that it actually separated later. The authors concluded that after 3 months, physiotherapist-guided pelvic floor muscle training reduced urinary incontinence significantly when compared to patients practicing on their own. So another RCT, this time it's Canadian from 2008, looked at a similar concept, incontinence following prostatectomy with a physiotherapist versus what they called supportive telephone contact by a urology nurse. So both groups received standardized instructions and a handout on 10 to 12 exercises that they were encouraged to perform at home 3 times per day at 4 weeks post-operatively. The intervention group also had weekly 30-minute biofeedback sessions with a pelvic floor physiotherapist for 24 weeks. The control group received a phone call from a urology nurse once per week for 12 weeks and then once a month. They used the measures of the 24-hour pad test, IPSS, IIQ7, cost, and perception of urine loss as a problem. Measures were taken at 1, 2, 3, 4, 7, and 12 months after surgery. So this group found that there was no significant difference between groups at any time point. But what was unique about this study was that they did consider cost, and it's a Canadian study, so this might be a little extra relevant for us. So they showed that the treatment group would have spent around $400 for the 24 weekly 30-minute biofeedback sessions. They reported that each session cost $30 per hour, and there was additional cost to each patient of $40 for the biofeedback probe that they had to buy. And then this was compared to that for the control, which they said would have been around $210 for around 21 sessions at $10 each. So even if these prices are not completely accurate in Vancouver in 2024, it still showed that not using a physiotherapist can be quite a bit cheaper. However, I think this would depend a lot on the extended health benefits of your patient, because sometimes it can even be free. But they did conclude that access to a knowledgeable urology nurse is cost-effective and just as beneficial as formal physiotherapy visits would be in promoting continence post-prostatectomy. So again, another RCT looking at similar themes. So this in 2010, they compared intensive physiotherapist-guided pelvic floor muscle training and an information pamphlet to what they called patient-led, where only an information pamphlet was provided to determine independent predictors of incontinence following prostatectomy. So in this study, 1 day before surgery, all patients received verbal instruction and an information folder on anatomy and exercises to strengthen the pelvic floor. And then those in the treatment group also got 9 30-minute sessions with a pelvic floor physiotherapist. This group looked at urinary continence as the primary outcome and defined it as less than 4 grams of urine on a 24-hour pad test, as well as less than 1 gram on a 1-hour pad test. They collected 24-hour pads at 1, 4, 8, 12, and 26 weeks after catheter removal, and collected 1-hour pad tests at 1, 12, and 26 weeks. So similarly to the previous study, they reported no differences in continence between the groups, suggesting that the patient-led format is just as good as the physiotherapist-led format. They also reported that greater urine loss 1 week after catheter removal might also be a predictor of persistent urinary incontinence. But in this study, they did note that due to under-recruitment, their study was underpowered. So this was a lot about prostatectomy incontinence, but now we can talk about post-prostatectomy erectile function. So a group out of Hong Kong published a meta-analysis in 2019 that looked at effectiveness of pelvic floor physio on erectile function and climacturia post-prostatectomy. Ultimately, they found 7 articles to include that compared some form of pelvic floor physio to no pelvic floor physio post-prostatectomy. 1,622 participants were included in the 7 studies. And in terms of erectile function, they concluded that there was no difference at 12 and 15 months for those receiving pelvic floor physio combined with electrical stimulation. Pelvic floor physio plus biofeedback had mixed results, with 2 higher quality studies reporting no difference in erectile function, and then 2 other studies, one high quality and one low quality, that reported significant improvement in erectile function at 12 months in the physio group. For pelvic floor physio alone, there was no difference in improving erectile function compared with control. Then in terms of climacturia, there was no significant improvement compared to controls for those in either of the treatment groups, the pelvic floor physio with electrical stimulation or the pelvic floor physio alone. So despite there being a potential role for pelvic floor physio in treating ED, as we talked about earlier, it seems that there might be less benefit for ED post-prostatectomy based on this meta-analysis specifically. So lastly, I'll talk about the role of pelvic floor physio following prostate cancer treatment as a whole. This final article I found didn't specify any particular prostate cancer treatment like the previous articles did, and it's the only one that included brachytherapy and external beam radiation. So this RCT was from 2015 and looked at 244 patients with stage 1 to 3 prostate cancer who completed treatment for at least 6 months and had incontinence symptoms, which they did include dripping as a symptom. They were randomized to 3 groups: biofeedback plus support, biofeedback plus telephone, and usual care. The biofeedback plus support and biofeedback plus telephone groups each received a 60-minute biofeedback session and learned pelvic floor muscle exercises using a biofeedback machine. They had pelvic floor physio sessions every 2 weeks for 3 months after biofeedback sessions. The support group had 3 to 5 patients per session in person with a physiotherapist for 60 to 75 minutes. The telephone group had individual phone calls with a physiotherapist for around 45 minutes, and both groups were encouraged to do their exercises 3 times per day. The usual care group received some information handouts. These groups were randomized evenly with no significant differences among anything including surgery, radiation, age, BMI, stage, demographics, baseline incontinence, or time from surgery. The primary outcome was urinary continence, and this was measured by looking at the average amount of leakage on 1-hour pad tests for 3 days. Secondary outcomes included quality of life, IPSS, and UCLA PCI. They found that at 3 months, both biofeedback groups had significantly lower daily urinary leakage frequency than the usual care group, but kind of like we've learned in all the other ones, this was no longer significant at 6 months. They did, however, have significantly lower IPSS scores and rated their incontinence as less bothersome than the usual care group at both 3 and 6 months. So this group concluded that both the biofeedback with a support group and biofeedback with individualized telephone support can be beneficial in treating incontinence symptoms in those who have long-term urinary incontinence following any prostate cancer treatment. So to conclude, pelvic floor physiotherapy has been proven to work as treatment for many different patient populations, although this isn't necessarily a huge improvement or a huge difference. There's no adverse effects to trying outside of cost if you're not covered or time. It might help in achieving earlier continence post-HOLIP or prostatectomy if the physio is started before surgery. The benefits seem to be a little bit less strong if started after surgery, but still could be helpful. So there was also this here, if anyone is particularly interested. This review went into extreme detail on what to include in a pelvic floor exercise regimen for men post-prostatectomy to help promote continence. Obviously, with time and everything, I won't get into it, but if you're interested, this is a good article. So that's it. Thank you for listening. Again, thank you to Dr. Kavanaugh for helping me put together a talk, and sorry my internet stopped there for a few minutes. Thank you for being patient with me for that.
Good. Thanks, Levi. We are short on time, so I'll open it up for questions for Levi. I guess while people are waiting, I guess we're thinking of one. My question to you, Levi, is what would be the anatomic or physiologic rationale to support testing the hypothesis that physiotherapy can help with post-prostatectomy